Hello everyone and welcome to Doses Pathology Review, and in today's video I'm going to continue talking about hypoxia, the most common cause of cellular injury. So we categorize hypoxia into hypoxemia, anemic hypoxia, ischemic hypoxia, and histotoxic hypoxia, and we said that ischemia is the most common cause of hypoxia. And in today's video we're going to discuss anemic hypoxia and histotoxic hypoxia. In anemic hypoxia, the amount of hemoglobin that is available to carry oxygen is reduced. The partial pressure of oxygen in the arterioles is normal, and the oxygen saturation is normal because each hemoglobin molecule in anemic hypoxia will be 100% saturated with oxygen, but the amount of hemoglobin that will carry this oxygen is reduced. And as a consequence, the total amount of oxygen delivered to the tissue is decreased, i.e. we have reduced oxygen content. And we said that the oxygen content depend on three factors. These factors are the hemoglobin concentration, the oxygen saturation, and the partial pressure of oxygen in the arterioles. And the most important determinant of the oxygen content is the hemoglobin concentration, and it is reduced in patients with anemic hypoxia. Generally speaking, hypoxia due to anemia is not severe at rest unless the hemoglobin deficiency is marked, because 2,3-diphosphodiesterase increases in the RBCs. So recall from your biochemistry lectures that glucose is metabolized inside the cells, and the process by which it is metabolized is called glycolysis, and this process is essential for generation of energy in the form of ATP. So one of the intermediates in this reaction is called 1,3-bisphosphoglycerate, and the metabolism of 1,3-bisphosphoglycerate is going to generate ATP. So in cases of hypoxia, the cell, the RBC, is going to sacrifice the generation of ATP in order to transform the 1,3-biphosphodiesterate into 2,3-diphosphodiesterate, and 2,3-diphosphodiesterate is going to enhance the ability of the RBC to release oxygen into the tissue. However, anemic patients may have considerable difficulty during exercise, because in exercise we have increased demand for oxygen, and because of the limited ability to increase oxygen delivery to the active tissues, these patients will present with difficulty of breathing during exercise. Sometimes the concentration of hemoglobin is normal, but it is non-functional, i.e. it is not available to carry oxygen, and this can be seen in two conditions. These conditions are methemoglobinemia and carbon monoxide poisoning, and this is also a form of anemic hypoxia. So let's discuss this in details. So in methemoglobinemia, we have hemoglobin with oxidized heme groups Fe+3. So heme is composed of heme and globin, and globin is just a protein, and heme is composed of iron and protoporphyrin ring. And iron can be found in one of two states. The first state is called the reduced ferrous Fe+2 state, and the second state is the oxidized ferric Fe+3 state. And the way by which I remember this is that the word ferric ends with the letter C, and the letter C is the third letter in the alphabet. So the ferric ion is the Fe+3, and Fe+2 binds O2, but Fe+3 cannot bind oxygen, and as a consequence the oxygen saturation is going to be decreased despite the normal partial pressure of oxygen in the arterioles. And as the oxygen saturation decreases, the oxygen content is going to be decreased. In addition to that, the ferric heme groups impair unloading of oxygen by the oxygenated ferrous heme in the RBCs. So if we assume that 50% of the ion inside an RBC is in the ferric state and 50% is in the ferrous state, the 50% of the ferric ion is going to impair the ability of the ferrous ion inside this RBC to release oxygen into the tissue, and this is going to result in hypoxia. Methemoglobin is normally generated inside our bodies in very low concentrations, and it is converted back to normal to the ferrous Fe+2 state by the NADH reductase system. Electrons from the NADH are transferred to cytochrome B5, and these electrons will be transferred to methemoglobin by an enzyme that is called cytochrome B5 reductase, and this transfer of electrons is going to reduce the methemoglobin into the ferrous Fe+2 hemoglobin. Newborns are particularly at risk for developing methemoglobinemia after oxidant stresses. Why? Because they have decreased level of cytochrome B5 reductase, the enzyme that is responsible for transferring electrons from cytochrome B5 into methemoglobin to reduce it into the ferrous ion. And this can be seen until at least 4 months of age. Now let's discuss the causes of methemoglobinemia, and it can either be congenital or it can be acquired. Congenital methemoglobinemia is seen in patients with congenital deficiency of cytochrome B5 reductase. Acquired methemoglobinemia can be seen in oxidant stresses, as in sepsis or by drugs. And the classes of drugs that can cause methemoglobinemia by causing oxidant stresses are nitrates, nitrite-containing drugs, and sulfur-containing drugs. Okay, patients with methemoglobinemia present with cyanosis when the methemoglobin level is low, less than 20%, and as the level of methemoglobin increases, they can present with headache, anxiety, dyspnea, tachycardia, confusion, lethargy, and lactic acidosis. Patients with methemoglobinemia have chocolate-colored blood and cyanosis, and we said that cyanosis is bluish discoloration of the skin and mucous membrane. And they have chocolate-colored blood because they have increased concentration of the deoxygenated form of hemoglobin, the deoxyhemoglobin, and the color of the deoxyhemoglobin is dark. So we said that they have cyanosis, but this cyanosis is unresponsive to the administration of oxygen because Fe+3 cannot bind oxygen. So how do we treat these patients? We treat them by giving them IV methylene blue, which accelerates the NADPH, methemoglobin reductase, and this enzyme is going to transfer electrons from the NADPH into methemoglobin, and this is going to reduce it into ferrous hemoglobin Fe+2 that can bind oxygen. And the way by which I remember this is that the word methylene blue starts with METH, and the word methemoglobinemia starts with METH as well. Vitamin C is an antioxidant, and it can occasionally reduce cyanosis associated with chronic methemoglobinemia, and it may be helpful in settings in which methylene blue is either unavailable or contraindicated, as in individuals with glucose 6-phosphate dehydrogenase deficiency. Okay, now let's start talking about carbon monoxide poisoning. And CO poisoning is the leading cause of death due to poisoning, and it is produced by the incomplete combustion of carbon-containing compounds. The complete combustion of carbon-containing compounds will yield carbon dioxide, CO2. And the causes of carbon monoxide poisoning include automobile exhaust, smoke inhalation, and wood stoves. And the classical scenario in which carbon monoxide poisoning is seen is in patients who commit suicide by locking the door of the garage and starting the car engine, and by doing so the concentration of carbon monoxide will gradually build up and eventually is going to result in death. And carbon monoxide is a colorless, odorless gas that can cause death without any irritation. So how does carbon monoxide cause hypoxia? Carbon monoxide has a high affinity for heme groups, and it competes with oxygen per binding sites on hemoglobin. And it is said that the affinity of hemoglobin for carbon monoxide is 200 times greater than the affinity of hemoglobin to oxygen. So if hemoglobin is exposed to carbon monoxide, it's going to bind avidly to this carbon monoxide, and oxygen will not be able to bind. And as a consequence, this is going to decrease the oxygen saturation without affecting the partial pressure of oxygen in the arterioles. And this decrease in oxygen saturation can be detected if blood is measured with a carbon monoxide oximeter. In addition, carbon monoxide inhibits cytochrome oxidase in the electron transport chain, and cytochrome oxidase normally converts oxygen into water. So inhibition of the enzyme is going to prevent oxygen consumption and shut down the electron transport chain. This is going to disrupt the diffusion gradient that is required for oxygen to diffuse from the blood into the tissue. Recall that oxygen diffuses down the concentration gradient from the alveoli into the arteries and then from the arteries into the tissue. And the constant consumption of oxygen by the tissue is going to maintain this concentration gradient, and this will allow oxygen to diffuse from the blood into the tissue. So if oxygen is not consumed by the organ, this is going to disrupt this concentration gradient and oxygen is not going to diffuse into the tissue. And similar to methemoglobin, carbon monoxide attached to heme groups impairs unloading of oxygen from the oxygenated ferrous heme in the RBCs into the tissues. So oxygen is not going to be released into the tissues, and as we said, oxygen saturation will be decreased, and this is going to decrease the oxygen content. Patients with carbon monoxide poisoning can present with cherry red discoloration of the skin and blood, and they can present with headache, dyspnea and dizziness, and eventually they can have seizures and coma. And the clinical presentation depends on the level of carbon monoxide in the blood of these patients, but it is worth mentioning that the earliest symptom with which they present is headache. So if you encounter any burn patient who was involved in a house fire and this patient presents with headache, you have to suspect carbon monoxide poisoning, and you can detect it by using a carbon monoxide oximeter. The lab findings in carbon monoxide poisoning include increased carbon monoxide levels in the blood if measured with a carbon monoxide oximeter, and they can have lactic acidosis because of the shift to anaerobic glycolysis. So glycolysis is the metabolic pathway by which glucose is metabolized to yield energy in the form of ATP, and the final product in the process of glycolysis is pyruvate when glucose is metabolized in the presence of oxygen. However, in the absence of oxygen, glucose will be metabolized into lactate, and lactate is going to build up, and this is going to result in lactic acidosis. And the third finding is reduction in the oxygen saturation with a normal partial pressure of oxygen in the arterioles. Treatment of carbon monoxide poisoning is done by administering 100% oxygen therapy with non-rebreather mask or endotracheal tube. Another option of management is hyperbaric oxygen therapy. And in hyperbaric oxygen therapy, we put these patients into chambers and then we expose them to oxygen in a very high partial pressure. And oxygen in a very high partial pressure is going to displace oxygen from hemoglobin, and this is going to result in a decrease in the oxygen saturation. Okay, now we're done with carbon monoxide poisoning. So let's head and talk about histotoxic hypoxia. And in histotoxic hypoxia, the amount of oxygen that is delivered to a tissue is normal, but because of the action of a toxic agent, the tissue will not be able to metabolize and consume this oxygen. Okay, and this is seen in cyanide poisoning. So cyanide poisoning is most frequently caused by combustion of synthetic products in house fires, and other causes include prolonged exposure to nitroprusside and suicidal consumption of cyanide compounds. And nitroprusside is a drug that is used in hypertensive crisis in patients who come to the ER with a very high blood pressure. So prolonged exposure to nitroprusside can result in cyanide poisoning. Cytochrome oxidase in complex 4 of the electron transport chain is inhibited by cyanide, and this is going to prevent the consumption of oxygen. Shutting down of the electron transport chain is going to prevent the diffusion of oxygen from the blood to the tissue, because there is a loss of the diffusion gradient similar to what occurs in carbon monoxide poisoning. And in addition to that, oxygen extraction by the tissue decreases in parallel with the lower oxygen consumption in the electron transport chain. And if the tissue is not going to extract oxygen, this is going to result in higher than normal venous oxygen content and partial pressure of oxygen in the venous blood. So in cyanide poisoning, the oxygen content of the venous blood is essentially the same as the oxygen content of the arterial blood, because this oxygen is not going to be extracted by the tissue. Okay, coming to the clinical presentation, cyanide poisoning most adversely affects the heart and the central nervous system. By affecting the heart, it can cause arrhythmias and cardiovascular collapse. And by affecting the central nervous system, it can cause seizures and coma. So the clinical findings include bitter almond smell of the breath, seizures, coma, arrhythmias, and cardiovascular collapse. Lab findings include lactic acidosis due to increased serum lactate levels from anaerobic glycolysis, and they have increased venous oxygen content when compared to the arterial oxygen content because there is no extraction of oxygen in the tissue. The treatment of cyanide poisoning is based on the high affinity of cyanide for two compounds. These compounds are the ferric ions in methemoglobin and cobalt in hydroxycobalamin. So we can treat these patients by giving them sodium nitrite. Sodium nitrite is going to produce cyan methemoglobin, and then we can give them a compound called thiosulfate. Thiosulfate is going to react with cyan methemoglobin, forming a compound called thiocyanate, and thiocyanate is going to be excreted by the kidney. And this treatment is limited by the amount of methemoglobin that you can safely form inside the patient without causing methemoglobinemia. Another treatment modality involves infusion of hydroxycobalamin, which is going to produce cyanocobalamin, and cyanocobalamin is going to be involved in multiple reactions that will eventually produce vitamin B12. Okay, lastly, we're going to compare anemia, methemoglobinemia, carbon monoxide poisoning, and cyanide poisoning. And in anemia, the partial pressure of oxygen in the arterioles is normal. The oxygen saturation is normal, but the amount of hemoglobin that is available to carry oxygen is reduced, and this is going to result in a reduction in the oxygen content. And the cytochrome oxidase is normal in anemia. In methemoglobinemia, the partial pressure of oxygen in the arterioles is normal, but the oxygen saturation is decreased because Fe plus 3 cannot bind oxygen, and the cytochrome oxidase is normal. In carbon monoxide poisoning, the PaO2 is normal, and the oxygen saturation is decreased, and cytochrome oxidase is inhibited. In cyanide poisoning, the PaO2 is normal, and the oxygen saturation is normal, but the cytochrome oxidase is inhibited. So as you can see, the partial pressure of oxygen in the arteriole is normal in all of these conditions. The oxygen saturation is decreased in methemoglobinemia and in carbon monoxide poisoning, and cytochrome oxidase is inhibited in carbon monoxide poisoning and in cyanide poisoning. And this is the end of this video.